Welcome back everybody, David here again with Med School Bootcamp. So now we're going to move on to our pharmacology section, and we're going to talk about all the highest yield medications I want you to know for test day. First, we're going to start with carbonic anhydrase inhibitors, then we're going to move on to osmotic diuretics, followed by loop diuretics, thiazide diuretics, potassium sparing diuretics, and finally we'll end with ACE inhibitors, ARBs, and direct renin inhibitors. Now, it's really important that you understand the physiology of the different areas in the tubules. So when we talk about loop diuretics, we're going to be talking about that physiology we talked about in the nephron transporter section. So if that's something you're not very confident in or you haven't seen in a while, I'd recommend you go back and check those out quickly. But if you are ready to move on to pharmacology, then off we go. So in this first video, we're going to talk about carbonic anhydrase inhibitors. And these are most commonly going to act at the proximal convoluted tubule. So remember, when we talked about our glomerulus, we know there are different areas, right? And the first area is the proximal convoluted tubule. And this is the most common area where our acetazolamide or our carbonic anhydrase inhibitor is actually going to act. So when we talk about the mechanism of action here, it's really important to think about what is the goal of acetazolamide. Well, it's really to block the formation of carbon dioxide and water becoming carbonic acid, and also the vice versa is true. It blocks carbonic acid from splitting into carbon dioxide and water. And if you draw your attention over here in the proximal convoluted tubule, we can see this reaction actually occurring in the kidney itself. And so if we take a step back a little bit and we think about normal physiology here, in the proximal convoluted tubule, we have lots of transporters that are acting to reabsorb molecules. We don't want to lose our sodium in the urine. In a healthy physiologic state, we want to reabsorb our sodium. We want to reabsorb our amino acids, and we also want to reabsorb our bicarb. However, the molecule of carbonic acid, the H2CO3, is too big of a molecule to actually move across the cellular membrane itself. And so what happens is the carbonic anhydrase enzyme right here splits this molecule into carbon dioxide and water. And these smaller, less polar molecules are actually able to make their way across the membrane itself. Once it's across the membrane, it can then be reconverted to carbonic acid. This carbonic acid can then actually split into a hydrogen proton and a bicarbonate molecule, which can then be reabsorbed in the body. So that's the way that we reabsorb bicarb. We don't just pull it from the cell directly. It actually has to get converted from carbonic acid to bicarb, go across the cell, get reconverted to carbonic acid, and then dissociate from the hydrogen proton. And so now this helps us explain what happens if we inhibit this enzyme. If we inhibit carbonic anhydrase, we decrease our reabsorption of bicarbonate. And this should make sense, right? Because the goal of carbonic anhydrase in the proximal convoluted tubule is to help reabsorb more bicarbonate. If we inhibit the enzyme, we're going to decrease the reabsorption of bicarbonate. If we decrease the reabsorption, what's going to happen? We're going to have an increase in excretion, an increase in bicarb leaving the body. Now, this one should make sense to you physiologically. Two other important points that they want you to know for test day are that acetazolamide can also decrease production of CSF in the brain and decrease the production of aqueous humor in the eyes. Now, the biochemical pathways of how this actually works is a bit unnecessary to know for this level. However, a way that I remember these just kind of as a memory hack is to remember this as acetazolamide. So C, that helps me remember the eyes and the decreased production of aqueous humor. And I also think of C for CSF. So again, acetazolamide, you can see aqueous humor, and CSF for decreased production. Now, it's important to know that acetazolamide actually has just a weak diuretic effect. And I mention this because we often think about kidney or nephrology pharmacology as trying to offload fluid. And sometimes that is the case. But when we're talking about our proximal convoluted tubule and we're talking about the use of acetazolamide, that is not the primary use for that drug. If we're trying to have a significant diuretic effect, we're going to use something like loop diuretics or thiazide diuretics to really offload that fluid. So the medications used in the proximal convoluted tubule only have a weak diuretic effect. It's not really what they're used for. We're typically using it to alter a patient's acid-base status, decrease their CSF production, or decrease their aqueous humor production. And again, we already talked about this is acting at the proximal tubule in the kidney. Now, moving on to the clinical usage. The first use we'll talk about is acute glaucoma. Now think about the mechanism here. Why would this be useful? Well, we just said that one of the things that this can do is it can actually decrease the production of aqueous humor. So in acute glaucoma, patients have a disruption in the flow of aqueous humor. So it can actually build up in the eye itself. This can be problematic and cause damage. So if we're trying to decrease the production of aqueous humor to help the patient out, then giving them acetazolamide is a reasonable choice. Now, this can also be used for alkalinizing the urine. And this should make sense again if we think about the pathophysiology here. We said that this is going to increase bicarbonate excretion. So more bicarb being excreted equals more bicarb in the urine, and that is going to alkalinize the urine itself. Recall, if there's more protons in the urine, that's more acidic. It's an acidotic state. But if there's more bicarb relative to those protons, that's more alkaline or a more alkalotic state. Now, keep in mind, we're talking about the urine here. So if we're alkalinizing the urine, what's that actually going to do to the serum? That's right. It's actually going to cause acidosis. If we're bringing back less bicarbonate, right? If this process is not working and less bicarb is coming back, we're actually going to have acidosis in the serum, in the blood, right? We're going to have an acidotic state. But in the urine, because we have more bicarb, we're going to have an alkalotic state. So don't get those confused. If they mention it's the serum versus the urine or the tubules, we need to keep those in mind. We can't let that word be overlooked because it can make all the difference when answering test questions. Now, moving on to the fun one that they love to ask you about, it is altitude sickness. So at altitude, right, there is a lower partial pressure of oxygen, whereas at sea level, about 21% of the air that we breathe is oxygen. The higher up you get, the lower and lower that gets. And so if we have a lower PO2 and high altitude, this is going to cause what response to the body? It's going to hyperventilate because our body is saying, where's the oxygen? We need more. We're going to have to breathe faster. We're going to have to breathe deeper. That hyperventilation is going to lead to decreased CO2 in the body. Remember, we breathe in for oxygen. We breathe out to remove our CO2. If we're breathing in quickly and a bunch of times to try to get in more CO2 because there's a lower partial pressure at the high altitude, this process is also going to increase our carbon dioxide excretion, right? Because every time we inhale, we have to exhale. So we're inhaling, trying to get as much oxygen as we can at the lower partial pressure, but that is always going to require an exhale at the end of that process. The decreased CO2 leads to a respiratory alkalosis because offloading CO2 causes a shift in the body that actually drops our hydrogen protons. So now we have a respiratory alkalotic state. This can lead to a variety of uncomfortable things for a patient, the most common one being headaches, but they can also get dizziness, they can get fatigue, and potentially some edema as well. And so acetazolamide is a medication that we can give patients prophylactically, where we say, hey, I'm going to altitude, I expect to have a respiratory alkalosis, I expect my respiratory drive to increase because I'm looking for oxygen at the lower partial pressure at high altitude. What can I do prophylactically? Well, if we know we're going to develop this respiratory alkalosis, we can give the acetazolamide, which increases our bicarbonate excretion. Why is this helpful? Well, if we're developing a respiratory alkalosis, we can give something to offload the bicarb. We can give something to offset the alkalosis that's going to develop. The bicarb excretion is going to help balance the alkalosis that will inevitably develop. And so we balance out the respiratory alkalosis by giving this prophylactically. Again, just to review, if we inhibit carbonic anhydrase, we block this reaction from occurring. This leads to a decreased reabsorption of bicarb, increased bicarb excretion. Now, we're kind of low on bicarb. We're a little bit acidotic. So when the respiratory system kicks in and creates a respiratory alkalosis because we've gone to elevation, now we're still at a more neutral state because we've prophylactically treated the alkalosis that we knew was going to develop. This can help improve patient symptoms so they don't feel as much altitude sickness. Now, this medication can also be used for something called IIH, or idiopathic intracranial hypertension. Again, getting back to the mechanism here. Well, this is going to decrease production of CSF. And so it makes sense that if a patient has intracranial hypertension, right, there's too much stuff in the cranium, well, giving a medication that decreases the production of more stuff is going to help improve their symptoms, or at least stop them from progressively getting worse. And finally, this can also be used for a metabolic alkalosis, and this should make sense, right? In a metabolic alkalosis, we have too much bicarb relative to hydrogen protons. We know that the medication here is going to increase our bicarb excretion. That is going to decrease the amount of bicarb in the body, and thus it can offset a metabolic alkalosis. Now, moving on to the adverse effects here. So one of the adverse effects is hypokalemia. Now, recall I said that this was a weak diuretic earlier on. However, there are still some diuretic effects. And so bicarbonate remaining in the proximal tubule can actually carry some sodium distally as well. And that's thought to in part be due to the fact that bicarb has a negative charge and sodium has a positive charge. So the negative charge is going to be attracted to the positive charge. And so as bicarb is being pushed distally in the nephron, so it's been here in the proximal tubule, but now it goes to the loop of Henle, this convoluted tubule, and a collecting duct, it actually pulls some sodium with it. Now, we talked about in the nephron transporter section, when sodium goes distally in the nephron, it will make every effort it can to actually retain that sodium. And retaining that sodium actually causes the excretion of potassium. So that is to say, distally in the tubules, sodium being brought back into the body itself actually kicks out potassium as well as hydrogen protons. And that is the reason that hypokalemia can develop from this medication. Although it's a weak diuretic effect, it does have some diuresis. Sodium is sent more distally in the nephron itself. The nephron makes every effort it can to pull back that sodium at the expense of potassium. Again, all of this was covered in detail in our nephron transporter section. So if this is unfamiliar for you, I'd recommend going back and checking out those videos one more time. Now, we can also get some other adverse effects, including kidney stone formation, right? We have an increase in urine pH. Why do we have an increase in urine pH? That's right, because we have elevated bicarb. Elevated bicarb is going to increase the pH, making an environment that is more suitable for stone formation. Some other less commonly tested ones include paresthesias, and this can just be due to electrolyte derangements or abnormalities that can occur with any of these medications. You can also see a proximal renal tubular acidosis, or an RTA type 2, because remember, what's the problem in an RTA type 2? That's right, the problem is with bicarb reabsorption. So this medication essentially mimics an RTA type 2. Giving somebody acetazolamide is going to keep more bicarb in the tubule itself, increasing excretion. Well, that's the same problem that a patient with an RTA type 2 has, or a proximal renal tubular acidosis. So draw that correlation. If they ask you a question, right, they could be giving you this presentation. Patients developing stones, they have elevated bicarb in their urine. But keep in mind, there's two possible things that can be causing that, at least at this level. One of them is the RTA type 2, but the second thing is that they're taking this medication. They're taking acetazolamide, which has a similar effect as the pathology RTA type 2. And finally, to wrap up this video, this can also induce an allergy for patients who are allergic to sulfa. This has to do with the chemical structure of the medication. There is a sulfa group on the medication, and that is why patients who have a sulfa allergy should be considered to try something else instead. So a classic vignette they might ask you to really highlight this point in a question is to talk about a 45-year-old man who is going on a skiing trip to Colorado with his buddies. They want to go to the highest peak there, go on all the black diamonds, and have a great time. However, several hours after arriving to the mountains, the patient starts to develop some nausea, some vomiting, maybe some headaches. So the patient is taken back down off the mountain and goes to the local doctor. Then the question can ask you, what medication would be useful for the patient? What medication might the doctor prescribe for this patient to treat their symptoms? Now, in this video, it's easy to say, oh, acetazolamide can help offset his respiratory alkalosis. However, you can imagine, right, if you didn't key into the fact that this patient was at a significantly higher elevation than he's used to, you might think it's just a headache, they might need some ibuprofen or something like that. And they'll give you all those different options. They might give you some loop diuretics to choose from. But if you see this classic vignette of somebody who's gone to an elevation that is far above what they're used to, they start to develop these kind of non-specific findings, lethargy, nausea, headaches. Think about the fact that they're at an area that has less partial pressure of oxygen. They're probably hyperventilating, they're probably in respiratory alkalosis, and you can give them a medication to essentially offset that. Now, ideally, acetazolamide would be used prophylactically, but it can also be used as a treatment option for this patient. So just in quick summary for this video, we talked about carbonic anhydrase inhibitors, how they typically act at the proximal convoluted tubule. Main one we need to know is acetazolamide. By inhibiting the carbonic anhydrase enzyme, we decrease reabsorption of bicarb, increase bicarb excretion. Two other things acetazolamide can do that we need to know for test day includes decreasing production of CSF, decreasing production of aqueous humor. We don't need to know the biochemistry behind how this actually works. We just need to know our memory aid, which is a C-tazolamide. To remember, we C the I for decrease in aqueous humor and the C in CSF for decreased production of CSF. Some classic things this is going to be used for include acute glaucoma because of what we talked about earlier, alkalinizing the urine. Altitude sickness is one of the favorite mechanisms they like to test you about on test day, so really understand this portion right here. This can also be used for idiopathic intracranial hypertension and a metabolic alkalosis as well, because we know this is going to decrease our bicarb in the body by increasing our bicarb excretion. Some adverse effects include hypokalemia. This has to do with its diuretic effect of taking sodium distally, which is then reabsorbed at the expense of potassium. This can also cause kidney stone formation by increasing the pH of the urine in the tubules itself. Paresthesias, proximal RTA, and a sulfa allergy can also be tested as well.